So I want to talk a little bit today about clinical informatics from dirt roads to superhighways. And the first picture over here is Montana's information superhighway. Generally, there might be a horse involved, or, it's not always pickup trucks, but that is where I started in Montana in 1995. We were about there. And today I want to talk a little bit about the journey, very high level, some of the roles that clinical informaticians are filling and how they're getting there, some of the trends, current and future, and then finally I want to end up with who's driving this bus. And to start out, I like to have this nice, pretty picture of the domains of clinical informatics, which are the nice circles with clinical care, information and communications technology, the health system, and in the middle of that, nice and clean, is clinical informatics. But this is really the reality of clinical informatics, right? I Googled one of the most confusing highway systems, and I got that. Because we have all these different disciplines, and we have all these different fields, many of them going in different directions, and we're all trying to put it together. So we are meeting and putting the patient in the center. Very early on, Hippocrates paved the road for the electronic medical record by talking about just the plain medical record and what it should reflect. And it should accurately reflect the course of the disease and the probable cause of the disease. And that's still what we're trying to do today with the electronic health record. And that's still what we're fighting against. Also, Hippocrates laid the groundwork for predictive analysis when he said that I believe that it is an excellent thing for a physician to practice forecasting. He will carry out the treatment best if he knows beforehand from the present symptoms what will take place later. And that's predictive analytics. And that is the Hippocratic Oath over there, in case any of you want to read it. Of course, we all know Florence Nightingale, and we see her in my profession as one of the first informatics nurses. Her birthday, by the way, was Tuesday, this past week, in case many of you celebrated. But the building block of informatics is collecting data. And Florence was one of the nurses who collected data and used it to improve patient outcomes. Interestingly enough, she thought in the Crimean War that it was nutrition that was causing poor outcomes, but she collected a lot of data on sanitation, and after the war, when she put that data together, she realized that it was poor sanitation conditions. So she created the first version of the pie graph, known as the polar area diagram, and that's a picture over there. And my husband said if I didn't use this, he would be unhappy with me because he went all over to get batteries. I want to walk through some just very high-level moments on our journey to our present-day state. And so in the mid-1960s, Pascal created a mechanical calculator. And in the 1830s, Charles Babbage, who's known as the father of computer science, created the first automated mechanical computer. In the late 19th century, John Shaw Billings was a doctor, and he was asked to help the Census Bureau tabulate data. And he thought, well, there's got to be a better way to do this than tick, tick, tick. So he talked to Herman Hollerith, who was an engineer, and he created the paper card, which many of you might remember in the early times, the key punch cards. How many of you worked with those? Yeah, all right. You're in my age range. Cool. And in 1980, they collected census data on 62 million people, and they processed that data in 1 month, right? Pretty cool. By the way, that machine was sold to Computing, Tableting, Recording Corporation in 1914. Does anybody know who bought them out? They changed their name to the International Business Machines, IBM, in 1924. In 1940, Bell Laboratories developed the binary system of the zeros and, the binary system of the zeros and ones for the on-off switches. And then in World War II, anybody see the movie The Imitation Game? That's recently come out, right? So the computer colossus that broke the German Enigma code. So now we know that computers can do something, right? Now we're beyond just tabulating data and calculating numbers. In 1946, the development of ENIAC, which is I'm going to have to read this, Electronic Numerical Integrator and Computer, was the first electronic general purpose computer, and it was designed to calculate artillery missiles firing, right, for the U.S. Army Ballistic Research Library. In the 50s, the first computer was used in the clinical practice, and I don't know how many of you remember that kind of mobile telephone. We've come a long way from there. In 59, Robert Ledley was a dentist who created the first CT scanner. He developed the first CT scanner. And he wrote this article, Reasoning Foundations of Medical Diagnosis, which was an expression of hope that by harnessing computers, much of the physician's work would become automated, and that many human errors could therefore be eliminated. Does that sound familiar? Right? And then in 61, the Department of Medical Methods Research was established by Kaiser Permanente to begin the use of the computer in the practice of medicine. And that guy right there is my dad. And he was in that era. He loved to play baseball. So my homage to my dad, who was my best cheerleader in my life, is he loved the Phillies. Go Phillies! Yay, Diane, right? So I'm taking him with me whenever I go anywhere on my journey. In the late 60s, they started developing EHR software, right? But it was mostly academic in academic institutions. I don't remember much before the 80s in institutions that I work in, and I mean in the late 80s. But in 1980, Atari came out, and IBM came out with their first personal computer, right? So that image up there is from the 1980 J.C. Penney catalog. The Atari 1800 with a whopping 16K of RAM. We couldn't even calculate on that today, I don't think. And then 2004, the Nationwide Health Information Network was created with the goal to connect all EHRs, health information organizations, and government agencies. So we're moving along now, right? Things are starting to heat up. In 1984 to 2003, the Human Genome Project was worked on, and that was mapping the DNA with the goal of determining the sequence of the chemical base pairs which make up human DNA, and of identifying and mapping all of the genes of the human genome from both a physical and functional standpoint. In 2009, the American Recovery and Reinvestment Act developed both incentives for developing EHRs that would be used to optimize patient outcomes and penalties for either not developing an EHR or not using it meaningfully enough for the government. Of course, the government laid out the criteria for meaningful use. And in 2012, I was reading an article the other day that it was noted that the hot trends in nursing specialties was nursing informatics. And it's still that way today. We need clinical informaticians to help us grow this product for people like my mom, who was with a little baby chick, and that was the year before she died. And she had trouble functioning through this world and needed help to keep her medical record. She moved out from Delaware to Montana to live with my husband and myself, and her medical records needed to follow her, and the doctors here needed access. And it was a very difficult process. So I want to talk a little bit about my journey that got me here. And you would all think that my journey in nursing informatics started when I became a nurse, but that's not true, actually. It started, I became a candy striper. My mom made me become a candy striper, by the way. And I worked at Wilmington Medical Center, and I would work on the floors, but when they didn't need me, my mom was a billing supervisor, so I would go down to her office, and I would be able to type and file and do things like that, and I realized, boy, I like this. I like my hands on this keyboard. And when it came time for me to move on and go to college, I wanted to be an actor. Southern California, anybody else wanted to be an actor, right? No? But my mom would not let me be an actor. She said, you have to go to college. Well, at that time, my favorite TV show was Emergency. Anybody remember Rampart General? Yeah? Yeah. And so I thought it was kind of cool. Dixie, the nurse, she kind of led everybody, the doctors, the paramedics, everybody. I thought that was cool. So I thought, okay, I'll go be a nurse. So I went to school for nursing. It's a good thing I didn't go into acting, I'm going to tell you that. So, I came out of nursing and moved around as a nurse and ended up in Hawaii for a period of time. And it was in Hawaii that I mail ordered my first computer. It was CompuServe and it had WordPerfect. And it came with a manual and I put it together and it was like, you know, because not only did I want to be an actor, I wanted to write. So I had my WordPerfect all set up to go. And at Maui Memorial Hospital, they had this very basic order entry system, which at the time I was a postpartum nurse. There's one of my little babies right there. And you would go in and check cord blood or check chest X-ray, and it would just print out down there. I mean, it wasn't anything more than that, right? So I came back and I moved to Montana and I was working in a small rural hospital, frontier nursing, as Charles says, and they wanted a person in the hospital to implement an order entry system. And I, as a person who traveled all over the place, I was still on night shift. I was 15 years in nursing and still on night shift. I wanted to come off night shift so darn bad. Oh. So I said, I'll do it. So I put a resume together. I knew nothing, and I didn't know that I was not the front runner, that there was a laboratory person that had ins for this job because she worked day shift and knew everybody, knew the politics. So the day I went in for my interview, I'm looking at my resume and I'm thinking, this needs something. And I added one bullet point, worked with order entry system at Maui Memorial Hospital. And I got the job. And when I went back and I asked the CFO, why did I get that job? He said, because you worked with an order entry system at Maui Memorial Hospital. He didn't know all I did was check chest X-ray. It was like, oh. And I was scared. I was so scared to do this because this was a complete change. And I was reading somewhere that every 10 years in your life you should make a complete change and start out again as a novice because it helps you be humble. Well, I was humble. In fact, there were times when I sat in the closet and cried. I was so humble. I was scared. So after a while, I was working in this small rural hospital, and I was, shall we say, a little unhappy with the wages. So there was a consulting job. I was headhunted. I thought, they don't want me. I work in a small rural hospital. And little did I know that small rural hospital people, they really want you. Because what do? You work in order entry, admissions, billing, lab, pharmacy. You do it all. You see all the integration. And sometimes when you work in a big hospital, you only see the one module that you're working with. So I went out into consulting, scared again, scared of flying, scared of being a consultant, just went ahead and did it. And after a while, I came back to Montana to work in another hospital there. And I've been there ever since. And as Charles would let you know, I went back to school and got my master's. 58 years old, going back to school, wasn't really that great in college anyway, a little bit nervous. And I had this wonderful husband who's sitting right there, who was having back surgery at the time, and he couldn't really do anything, but he could read. And I was taking, conceptual models of nursing. So every night he couldn't sleep, so he would get up and read into a tape recorder conceptual models of nursing. And then I would listen to it as I drove back and forth to work. And I know, yeah! So that's my second cheerleader in life. My dad's first, he's my second. And he slaughtered some of the words, by the way. But we got through it. And then I met Charles through the Winnie program. I was doing a Winnie, and he came out and helped me with it. And when he moved into the vice president role, he asked me if I would move into the interim West Region Director role. Guess what? I was scared again, but I did it. And so now I'm West Region Director. I also function as a clinical informatics quality supervisor for Kalispell Regional Healthcare in Kalispell, Montana. And this is my husband and I at our wedding. And the reason I put that there is because I didn't go in the water because I was scared. So by that, there are many paths to clinical informatics, right? And this kind of layout does by no means mean that you hit one to the next, to the next, to the next, to the next. We start in many different ways. I just wanted to come off a night shift, right? And I forgot how much I love the keyboard. And then I got to the keyboard, and I was like, oh, yeah, I love this. So, you know, you start mostly on the job, some form of on the job in healthcare. You might become the go-to person on your unit, right? And then the IT department's coming to you. Committees, you can sit on any committee today in healthcare, has to do with IT. So find the committees that you like to have input on and get on those committees. You may be a super user or sit on a core team. And at that point, I see many people getting hired into the IT department from the clinical piece. Or hired by vendors. But, you know, hiring by vendor, usually you need to know the software first. And then you can move on to your higher learning or your credentialing, right? So much is going on today. And when I went back to school, I just wanted to know what I knew and what I didn't know. And every course I took just amazed me at how much other people did. I hated finances, hated it. Took a finance course and thought, wow, he's not just a bean counter. There's a lot to this. Took a public health course. Wow, they're not just, you know, people that just go out and visit. There's so much more to it, and it just expanded my horizons. And by the way, I do want to go back to Hawaii for 1 minute and let you know how I know I'm a lousy actor. And this is Southern California, so I have to do my California moment. While I was there, Richard Hatch came and did a 3-week seminar in which we ended up putting on a little presentation, and I sucked. I was awful. So I'm really glad that I got back to the keyboard and not acting, but it did get me away from being so shy, because then I was painfully shy. And people that know me now know I'm not so painfully shy. So if you're interested in going forward, and nursing is my background, and I know it's not all of your backgrounds, and there's a lot of different areas that you can come in, but this is the one I know. In an undergraduate level, there's informatics nurse, and that's generally an RN with experience in the informatics field, mostly on the job learning, right? The graduate level, the master's is the informatics nurse specialist. And this is the person, like myself, who is going to lead a clinical informatics department, lead clinical informatics initiatives, and then there's the postgraduate focus, which you can do your PhD and be academic, or you can do your DNP and be more in applied practice. And that's where we're wanting our CNIOs to go, in that direction. And then for credentialing, the ANA did recognize nursing informatics as a specialty in 1992. They have 2 scope and standards out. The 2nd edition just came out this year. Excuse me, and their description of nursing informatics looks a little bit like that highway, you know, with all those things intersecting. It got a little big because it's just getting broader and broader. And there are these different certifications, the nursing informatics, the CP HIMSS, the American Board of Imaging. I think there was a veterinary one. I couldn't get a picture of it. But there's all those different certifications and all of these professional organizations that are out there. And so that's why I'm glad so many of you are here today. Because, by the way, your Southern Cal membership almost tops the American Nursing Informatics nationwide membership. So you should be very proud of yourselves. But I have a lot of work to do with the NIA to get more members. So there are so many promises about clinical informatics, and I just wanted to show you something from the 60s.
We have here a joint study undertaken in 1961 with the International Business Machines Corporation for the purpose of determining if it was possible to eliminate the paperwork, or at least part of the paperwork, which has burdened the nurses and doctors in hospitals for these many years. In 1964, 15 input and output terminals were installed throughout the hospital. 7 of these were put at the nurses' stations, and the balance at the ancillary departments. These terminals have many purposes. The one in the admitting department is to record the indicative information on each patient as he is admitted, and then transmitted to the patient's floor. The terminals on the floors record the information and the orders for medications and tests as they are generated at that floor and as written by the doctors and nurses. This information, in turn, is sent to the central computer and is then related back to the ancillary department involved. Now, so far as drugs are concerned and orders of this kind, the nurse at the desk is reminded at a specific time of day when she should give the drug and in what amounts. In spite of the relative short time that we have been working with the terminals, we now can see certain advantages that are taking place. It is going to be possible to relieve the nurses and the doctors of some of their paperwork. It is going to be possible to have correlation of diseases which we have not had before. And it is going to be possible to eliminate errors in medications and in tests of this kind, which would have been harmful to the patient.
Oh yeah, the promises. El Dorado, the fountain of youth, improved efficiency of care, decreased fragmentation of care, decreased redundancy, decreased transcription errors, enhance outcomes, evidence-based decision support, decrease costs, using the computer as an adjunct for critical thinking, enhance population health. These are some of our promises that we have been promised. But there's a few challenges. And I don't have GW up there because he had something to do with beginning all of this, because I know he did, but I have him up there because when I Googled images of challenges, right? And found all these lovely images, he was right there in the middle. So I had to put him on here because he was there. And we still have the challenges. When I started in '95, I struggled through many of the same challenges that are out there today. In some ways, it feels like nothing much has changed. Lack of system interoperability. The technology doesn't meet the functional requirements. We can't accommodate caregiver workflows, and we're having to accommodate vendor workflows. Clinical subject matter experts aren't there in all phases of the design, so there are inadequate workflow designs. Human factors, aging populations, and some of the very in-the-weeds things where, do I use checkboxes or do I use notes? How do I tell the patient's story? And how do I use the computer as an adjunct for critical thinking and not have nurses dummy it down or clinicians dummy it down and stop critical thinking? I had the most incredible phone call on the help desk where the computer system went down and a nurse called me and said, I can't get a diet for my patient. I said, pick up the phone. So we're struggling against that. We're still struggling with not having standardized language across the board. However, we are getting somewhere. We have gotten to the point with acute care where the patient is, in the middle of that, and now our trends are emphasizing the changing in delivery models, so we're providing more care outside the hospital. It's more cost efficient, it's clinically relevant, the patient is definitely in the center of that. So we've done a lot of work on patient engagement, population health, bioinformatics now, genomics. These are all places where we've moved to because we finally have started to get some of the other pieces into place, although not perfectly. And now we have the rise of analytics. So we have opportunities to participate, create, and shape tomorrow's healthcare. And all of us are involved in that. Social media is really putting the patient in the center. So this trend where Twitter and Facebook and all these social media sites are helping us to see infectious disease outbreaks and things like that. So we have, again, the patient in the center. We have a lot of individual apps for monitoring, tracking, and trending. My friend just got the iWatch, and it tracks her heart rate, all those things that we can do with our phones. But she was sitting there, we were having a discussion, and it dinged, and I said, what's that? And she said, oh, it's telling me I've been sitting too long, I have to stand up. I'm like, I think I would get angry at a device that did that. But we have all of these individual apps that people are starting to embrace and want. And it's scaring physicians, I know, but I like to keep track of how many steps I walked and how many stairs I walked during the day, and I get angry because I took my phone and set it down, and it's not counting every step for that period of time that I set it down. So we have these past challenges that are still with us that have to meet the future trends, right? And so there's all these new healthcare data sources, RFID, and it's so funny because Charles gave me this slide so that I could use it, and I spent a lot of time looking up philological monitors and philology. And there is a term out there, but it's kind of an ancient medieval term for studying data structures, so I thought, that can't be right. And so I said to him this morning, quick, tell me what that means. And he said, oh, I think I misspelled physiological. I'm like, oh, good, I'm not that far behind the track. Oh, good. I am behind the track because I'm behind my notes here. Hold on. So, yep, social media, geographic information systems, open data is the home of the U.S. government tool that's set up to help you find data, tools, and resources to conduct research, develop web and mobile applications, design data visualizations, and more. So that is very cool. We're getting, thank you very much, 10 more minutes, okay. We're getting there, and we're the Internet of Things, right? I'm going to connect with my home. I'm going to tell it, my husband was telling me that when he has a friend who, when he gets off the plane, he starts his oven at home so that when he gets home, he can put the pizza in. Yeah, right? And then FHIR. FHIR is the new fast health interoperability resource it builds on previous HL7 data structure, but it uses web-based HTTP application programming interface, right? So this is going to be the first, it's going to be where individuals can carry their health record on their smartphone, you know, on their iWatch, all of that stuff. So these are future trends. And then there's the smart devices, right? The smart toilet. Anybody heard of the smart toilet? It measures specific gravity. It measures amount of bowel movements. People are in their home. They're going to get a little dehydrated. And but who's driving this train, right? There's a lot more new drivers out there. You know, user experience. We see now that we're putting the patient in the center, right? Human and computer interaction, devices, wearables, all of this. And now you are all on the team, right? And that is a picture of my HIT squad that I worked with. And I wanted to call it the Super HIT Squad, but they didn't like the acronym. And I just want to end with, although we keep talking about putting the patient in the center of things, I think we have done that. And I can't help but think that we need to create a space to put us in the center of things. You're standing on the shoulders of thousands of people who came before you and did work, and you're standing beside thousands of people who are doing the work. And how many times did I say today that I was afraid or fearful of doing something? But I just went forward, and I let my cheerleaders, thanks Dad, thanks fella, keep me going. And you all have to be cheerleaders to each other and to yourselves, and find your best cheerleaders. Because the innovation needed today requires strength and a little bit of fearlessness. I heard a young woman speaking on Montana Public Radio regarding a challenge that involved creating a new app. This was a 16-year-old girl, and she said, I'm paraphrasing a little bit, if it doesn't work, no big deal. Don't expect it to work the first time or even the 10th time. You go in, you build, you try it out, and you try it again. today's innovation is not dependent on high-ranking executives, but on the person that has some knowledge of the patient, the clinical workflow, and who has the courage to go out day after day and re-hit some of those dirt roads, re-hit, because you will, they will come back. And when you have one of those dirt roads, you have all of these organizations, you have all these groups, and you have all these people who are standing beside you who can help you. So reach out and make it work.